Hello everyone, this is Shadi Rais from SCAI 2024 in Long Beach. I'm really excited to be with Dr. Azeem Latib, who is the late breaker presenter at SCAI 2024. Congratulations for the trial.
Thank you so much.
So again, this is a first-in-human trial about a new technology, a new valve in the aortic valve space. Tell us about the study.
Yeah, absolutely. So the valve is called Durar. It's a new balloon expandable valve, but what makes it unique is the leaflet technology. So as you know, for most valves, whether they're transcatheter valves or surgical valves, they're 3 leaflets, but the leaflets, they're either bovine or porcine pericardium, but they're 3 individual leaflets that, when they prepare, they laser cut, you then choose 3 leaflets that are the same, and they individually sewn in. What's unusual about this is it's a single leaflet technology. So they take a single leaflet, they then use 3D shaping to shape it to look like native aortic valve leaflets, and then they stitch it into the valve frame. So that's why they call it a biomimetic valve, because what they're trying to do is copy the native aortic valve and make it look as similar to the native aortic valve as possible. So balloon expandable, this interesting new bovine technology, single leaflet that's 3D shaped with it's called ADEPT technology for anti-calcification, and it allows you also for commissural alignment, so you can align the commissures.
Different sizes?
So right now in the clinical study we only did one size, so we decided to start out with the hardest size, which is the 23, right? So we have a small valve size that can treat between 21 and 24 millimeter annuli, because we figure if you're going to show that a technology works and that a technology has good hemodynamics, then you've got to go to the small annulus. Because once you go bigger, it's easier, right? Because the hemodynamics are going to be good. So let's go to the small area. And I got to tell you, I'm so glad the company decided to do that, because now we just had the SMART trial published. Everybody's talking about small annuli and about women and what's the best valve.
And the hemodynamics.
And the hemodynamics, right? What's better, supraannular, intraannular, and how do we give patients with small annuli good hemodynamics?
So let's talk about the enrollment and the design.
So this is a first-in-human study. We treated 28 patients in the single-arm, single-center study. We treated all the patients in Tbilisi, Georgia. That's where we went to start the study. Implantation success was 100%, okay? 30-day mortality, 0. 30-day stroke rate, 0. 2 patients who had pacemakers. We have now 20 patients up to 1-year follow-up. At 1-year follow-up, there's 1 mortality. A patient was in a car accident at 360 days, so not related to the valve. And no strokes at 1 year. So really good overall outcomes, small numbers of patients. But I think what's the dramatic part is the hemodynamics. So like I mentioned, it's a small valve. The average annular diameter is just over 21 of patients treated. Okay, so small annulus. And the hemodynamics we're getting after treatment, single-digit mean gradients, so around 8.5 at 30 days, 6 months, and 1 year. It still stays around 8, and valve areas just above 2. That stay above 2 at 1 year.
Nice.
Okay, so very unusual to get for an intraannular valve. Okay, such good gradients, and I think the reason we get such good hemodynamics is the way the leaflets were designed. The valve is a very large coaptation zone. When you see the valve on echo, most leaflets just like coap like this. This valve coaps like this, and when you look at other valves, you see them open this much. This one looks like it's almost opening, hitting the frame. It doesn't touch the frame, but it almost opens vertically like this. So you end up with a very large effective orifice area.
Absolutely. And then in terms of hemodynamic or echo data, do you have that studied?
Yeah, absolutely. So like I said, we're seeing aortic valve areas over 2, 2.1 to 2.0 to 2.1, mean gradients 8, DVIs like 0.6. And so they're staying very well. The other thing we're doing, which is interesting, is MRIs. So we're doing MRIs to look at flow out of the aortic valve. And one of the things we're seeing on the MRI is we're seeing what looks like very laminar flow. So not a lot of turbulence, that a large orifice area with very good laminar flow.
Which can help durability down the line as well.
Well, that's what we hope, right? I mean, let's face it, to know if a valve is going to be more durable than another valve, we're going to have to wait 10 years, right? And it takes time. But in the interim, all we can do is try and figure out that if a valve has better hemodynamics now and maintains like that over the next few years, to me, it's very suggestive that at 10 years, it's going to be better.
Right.
Right?
Yeah,
And I always ask patients, and I'll ask you, if you had to choose a valve for your family member, right?
Yeah.
And I gave you 2 valves, and I say we don't know the durability at 10 years. At 5 years, they're both fine.
Yeah.
Valve A is going to have a gradient of 8. Okay?
At 5 years.
At 5 years, or 1 year, let's say. Valve B at 1 year is going to have a gradient of 18.
8.
Which one do you want? 8 or 18? You want 8, right?
Absolutely.
Because I think we hope that if you have the
It'll
lower
last
graded,
longer.
it's going to last longer.
Yeah,
Right.
yeah, more time, yeah.
And there's some data to suggest that.
Yeah. Well, congratulations, Dr. Latib. Again, great study again as first in human. And new therapy again for the aortic space, always evolving. We thought we were done with the TAVR, but always something
Always a
comes
lot
up.
of news.
Always.
Absolutely.
Watch these videos and others on SCAI TV. This is SCAI 2024 Scientific Session. Thank you so much.
Excellent.